Our first speaker is Professor Einar Stefánsson, who will present the effects of vitreous and vitrectomy on ocular physiology and cataract formation. Einar?
Now, I will speak about the physics and physiology of the vitreous humor in the context of vitreous surgery and the changes that take place in the vitreous through our lifetime and what the clinical consequences are of this. Now, having worked in ophthalmology for more than 3 decades now, one tends to have a historical perspective, and it's just amazing how much our thoughts of the vitreous humor, the vitreous gel, have changed even in my lifetime or in the time of my career. I remember intracapsular cataract surgery. And at that time, the vitreous was untouchable. If you touched the vitreous, if something happened to the vitreous, the eye would basically die. We all knew this. Now then came vitrectomy. And now we could remove the vitreous and throw it away. And we really thought that that would have no consequence. That we could just take the vitreous away, replace it with water, and there would be no consequence to other tissues of the eye. At that time, the vitreous was also pretty much invisible. Yes, we had the slit lamp, we had some ultrasound, but really no good ways of examining, especially the posterior part of the vitreous, PVDs and things like that. Now, all of this has changed, and now we know the vitreous is none of these things, and is very much at the center, not only of the eye, but the center of ophthalmic physiology. Now, what we found out early on in the context of vitrectomy was that there were clinical and physiological consequences of, let's say, removing the vitreous. One of the early observations was that if you removed the vitreous in a diabetic eye, you did not have retinal neovascularization come back. So vitrectomy pretty much stopped the process of retinal neovascularization. But at the same time, these eyes would be at increased risk for iris neovascularization in the front of the eye. So it was a great speculation at the time, why does this change so much? Same thing with diabetic macular edema. In the early 90s, we found that vitrectomy improves diabetic macular edema. It reduces the thickness of the retina, and in some cases improves the vision. And then a negative aspect is that following vitrectomy, you indeed get cataracts. You get nuclear sclerosis cataract. So all of these are clinical consequences of removing the vitreous and replacing it with water. And I will discuss some of the mechanisms. Why is this happening? And then we will also look at how does this extend not only to vitrectomy, but also to the natural changes that happen in the vitreous cavity. Now, one of the characteristics of the vitreous humor is that it is a viscous gel. You all know it's 99% water, so chemically speaking, it's very close to being water, but it's highly viscous. And what difference does the viscosity make? Well, the viscosity affects the transport of molecules across the vitreous cavity. So whether that transport is by diffusion or by convection currents, the transport is reduced linearly with the increased viscosity. So if the viscosity of the vitreous gel is, let's say, 5 times that of water, it slows down the transport of glucose or oxygen or VEGF 5 times. So you can say that the role of the vitreous gel is to modulate, is to slow down the transport of molecules, and this is all molecules, across the vitreous cavity from the retina to the lens or from one area of the retina to another. This is something that is known from classical physics, and I'll scare you with a few formulas. I'm not going to dwell on them, but if we look at Fick's law of diffusion, you can see the diffusion coefficient, which is a capital D, and Stokes and Einstein worked out a formula for the diffusion coefficient. You see capital D there. And the important part is that it is inversely related to the viscosity of the medium. And the same is true for the formula for fluid flow, which I am sure you know well, the Hagen-Poiseuille law. Also their viscosity is inversely related to flow. And of course, this makes intuitive sense, that indeed the more viscous the medium, the slower the fluid flow, and the slower the diffusion. So this is common sense, but it's also classical physics, and it's something that we have confirmed with direct experiments. You see the reference below. Now, back in the 1980s, we worked on this in animal models, and one quite important experiment which was done at that time is shown here to show how vitrectomy influences hypoxia in the retina. So what we did was to create hypoxia by inducing a branch retinal vein occlusion in cat eyes, and then had previously done vitrectomy in one eye and not in the other eye of each cat, and then measuring the oxygen tension over the retina or in the vitreous simultaneously in both eyes in a number of cats. And you can see the histogram below. It shows you that before the branch vein occlusion, you have a normal and similar PO2 level of about 20 millimeters of mercury, both in the normal eye and the vitrectomized eye. But then when the branch vein occlusion is introduced, you can see that the normal eye, that is the non-vitrectomized eye, shows quite dramatic hypoxia, which is what you expect when you occlude the blood vessels. But that's not the case in the vitrectomized eye. So the vitrectomy somehow protected the retina from becoming hypoxic when ischemia was introduced. And here's an explanation for what happens in a schematic. So on the left-hand side, you see what is supposed to be the normal eye with the vitreous gel intact, and the fluxes of any molecule, oxygen, VEGF, drug molecules, glucose, I mean, this is true for any molecule, are quite slow through the viscous gel of the vitreous. On the right-hand side, you see a vitrectomized eye. So now the vitreous gel is gone, there's just fluid there, just water. And now the fluxes of, let's say, oxygen and VEGF and everything else are increased. And since the difference in viscosity between water and vitreous gel is at least 5 times, we're talking about the fluxes being increased by at least 5-fold. So we have a much more effective transport of these molecules across the vitreous cavity. And this has positive consequences and it has negative consequences. Nancy Holekamp and David Beebe in the United States looked at this in the human about 10 years ago and ongoing research. And they indeed confirmed that in the vitrectomized eye, the PO2 in the vitreous is higher than in a non-vitrectomized eye, exactly because the oxygen fluxes from the retina into the vitreous are faster. And they pointed out that this is damaging to the lens, because the lens in the normal eye is basically hypoxic. I'll go back to show you that. So if you look at this, in the normal eye, the oxygen flux from the retina to the back of the lens is very slow in the normal eye, and the PO2 at the back of the lens is very low in the range of 7 to 10 millimeters of mercury, whereas in the vitrectomized eye, where the flux is much faster, now the back of the eye, back of the lens has PO2 of maybe 15 to 20, and as a consequence of the increased oxygen, the lens develops a cataract. So this is a negative consequence of the increased oxygenation of the lens, and this was indeed pointed out by Holekamp and Beebe. Here we see another slide from them showing again on top the normal eye with the very little oxygen flux from the retina into the vitreous gel, and then below the vitrectomized eye, more oxygen flowing from the retina to the lens, and then the increased oxygen results in the nuclear sclerosis cataract formation. Now, what Beebe and Holekamp have also pointed out is that there is an antioxidant in the vitreous gel. This is vitamin C, this is ascorbate, and as oxygen diffuses into the vitreous gel at higher rates, it oxidizes the ascorbate, and so the concentration of that is reduced. So the reduced levels of ascorbate in the vitrectomized eye is a consequence of the increased oxygen fluxes. So it's another biochemical change that happens as a consequence of the change in viscosity. The fact that vitrectomy leads to an increased oxygen tension in the vitreous cavity has been shown with a variety of techniques. I've shown you some of the invasive technologies, both in the animals and in the human. There's a recent paper in IOVS where this was shown with MRI imaging, indeed showing a higher oxygen tension in the eye after pars plana vitrectomy. And the same thing has been shown by Martin Seen in the Czech Republic using retinal oximetry, where the imaging device is used to measure the oxygen saturation of the retinal arterioles and venules. You can see on the image below the oxymap image, where the red color, you can see the scale on the right-hand side. The red color of the arteriole shows that they are 95% saturated. The green color of the veins shows that they are 50 to 60% saturation. And Martin Seen used this technology to demonstrate that following vitrectomy, indeed, the oxygen saturation of the retinal veins was significantly increased. So we have basically 4 different technologies that have demonstrated and validated that indeed there is this change, this increase in oxygen tension in the vitreous cavity following vitrectomy. Now, this summarizes a little bit the situation. So if we have in the top left corner, you have what is the normal eye. And so again, the vitreous gel is filling the cavity. The transport of, let's say, VEGF or oxygen, to take those examples, is very, very, very little. This also means that if you have an ischemic area, a branch vein occlusion, or an area of capillary non-perfusion in diabetes, you have very little chance of oxygen coming from, let's say, a better perfused area to contribute to that zone. And also, the VEGF that may be produced in that ischemic area cannot diffuse away, cannot escape at any large or any speedy way. On the top right-hand side, you see the vitrectomized eye. So here, these fluxes are much greater. They're 5 times greater or more. So now, if you now imagine an ischemic area, a branch vein occlusion, let's say, or an or a capillary non-perfusion in diabetes. Now you can have oxygen flowing from the other side of the eye, from a well-perfused part of the retina, to relieve the hypoxia, as we saw in the beginning in the cats. And also the VEGF and other cytokines that may be formed in that ischemic area can now escape. They can be cleared into the vitreous cavity and escape from that area of ischemia. Below, on the right-left side, you have the silicone oil-filled eye. Silicone oil is very viscous and sort of replaces the vitreous gel. The high viscosity, again, slows down the transport. So the silicone oil-filled eye is physiologically somewhat like the normal eye with the vitreous in place in that sense. And then on the lower right-hand side, you see the one-chamber eye where the lens is gone also, and these currents are even greater. Now, when you know this about the physiology of the vitreous, you can put it into context with the pathophysiology of ischemic retinal disease and how we are treating it. So in the center here, you see a schematic, somewhat simplistic, flowchart of the pathophysiology, or let's say of diabetic retinopathy. We have ischemia and hypoxia at the top, which through the hypoxia-inducible factor leads to the production of VEGF. VEGF then gives us neovascularization and edema. And if we think about how our treatment approaches influence this, vitrectomy reduces the retinal hypoxia, the local retinal hypoxia. We've just seen the data for that. Retinal photocoagulation also does that through a different mechanism. It destroys the photoreceptors, reduces the oxygen consumption of the retina, thereby reduces hypoxia. So that's where those treatment options fit in. Then when we get down to VEGF, well, if we do a vitrectomy, and we now have this low viscosity fluid in the vitreous cavity, VEGF and other cytokines can now escape from the retina. They can be cleared from the retina into the vitreous cavity. So their concentration in the area of ischemia, be that in an area of diabetic macular edema or an area of AMD, neovascular AMD, the VEGF can be cleared out. So the concentration is lowered. Of course, at the same time, we inject the anti-VEGF drugs for the same purpose. And keep in mind there that the effect of vitrectomy is mirrored by the effect of a vitreous detachment. So if we have a vitreous detachment, that has pretty much the same physiological or metabolic effect as does vitrectomy, meaning there is now low viscosity fluid in front of the retina as opposed to a high viscosity gel. And we are learning slowly, and there is an emerging clinical association between vitreoretinal adhesion and some of the macular diabetic macular edema and neovascularization in diabetes. Same thing in AMD. Basically, if you have vitreoretinal adhesion, that eye is more likely to develop macular edema. It is also more likely to develop neovascularization. Now, the conventional explanation for these clinical observations have always been that there must be traction causing the edema. Sometimes there is, but not in all cases. And that the neovascularization effect is because you need the vitreous scaffold for the vessels to grow on. Now, the vitreous scaffold idea is absolute nonsense because vessels can grow pretty much on any surface, including the retina itself. So they don't need a scaffold to grow on. The reason why, like in diabetic retinopathy, the vessels only grow into the vitreous and only grow where there is vitreous is because of the metabolic effect of the vitreous, not that it is needed as a scaffold to grow on. So the metabolic effect of the vitreous gel is quite an adequate, or at least a possible, explanation for these clinical phenomena. We mentioned, though, that vitreoretinal traction is real, and of course, in some cases, it is the reason for macular edema. So, macular edema can be stimulated on one hand simply by the vitreous adhesion, but also by the traction. But let me ask you, how does traction cause edema? What is the mechanism for traction causing macular edema? And this takes us even farther back in classical physics and physiology, because this takes us back to Newton's third law. So, as you see here, Newton's third law is that for every action, he called force an action, so we would say for every force, there's a counterforce, which is equal and opposite. So when we have when we have vitreoretinal traction pulling on the retina, a force pulling the retina anteriorly, as we see on the schematic, well, there's an opposite force pushing the other way or pulling the other way, and what we have in between is vacuum, is a reduction of the tissue pressure. And we know from another Englishman, this is Starling from the 19th century, Starling's law, who talked about how edema comes to be. So there is the balance between the hydrostatic pressure, the pressure difference between the capillaries and the tissue on one hand, and then the osmotic pressure on the other hand. And it's very clear that if we lower the tissue pressure, we increase the pressure difference between the vessels and the tissue, and water will flow down that pressure gradient. So this is how, and the physics explains this very nicely, this is why traction causes or can cause retinal edema, and why releasing that traction will make the edema go away. So completely different from the metabolic physiology I was telling you about before. This is mechanical physics. So to summarize, so what the vitreous humor does is that it controls the transport of molecules through the vitreous cavity. That's basically its metabolic function. It's to modulate the transport of molecules, and this of course means all molecules. So if the viscosity is reduced, either by vitrectomy or by vitreolysis or by the normal degeneration of the vitreous, this will increase the transport, speed up the transport of all molecules, and this includes, for example, oxygen, cytokines, drugs, and everything else. And so vitrectomy, vitreolysis, vitreous detachment all have this physiological effect or metabolic effect. And we can use this physiology, and when we understand this physiology, it helps us understand both the beneficial effects of vitrectomy or a posterior vitreous detachment on the development of retinal neovascularization, for example, in diabetes or even in AMD, the development of macular edema, for example, in diabetes, and also the harmful effects, which may be iris neovascularization, cataract formation following vitrectomy, and possibly glaucoma. So with that, I thank you kindly for allowing me to participate. It's great to be with you here in Barcelona. Thank you.
This paper is now open for discussion, comment, and questions. You're invited to step up to the microphone and please state your name and city of origin. While you're doing that, I'll ask Einar a question related to vitrectomy. Can you envision ways to mitigate against the increased PO2 levels following vitrectomy by either modifying the procedure, and as a corollary, can you envision ending a vitrectomy with an injection of vitamin C or other free radical scavengers that might help the physiology?
Yeah, I mean, there are several possibilities. I mean, one possibility which is already being done is that people are indeed doing limited vitrectomies for posterior pole surgery, like epiretinal membranes or something like that, leaving some of the anterior vitreous intact, just doing the vitrectomy in the back and leaving the anterior vitreous basically to cover the lens. Now, of course, when we do vitrectomy in the conventional way, and we are infusing the eye with water or saline, which is basically at ambient oxygen level, so it's 21% oxygen. So then, of course, we are for a couple of hours putting in very, very high levels of PO2 in the eye. Now, whether that has any short-term effects, we don't really know that. But it would be reasonable to lower this to what is the physiological PO2 in the eye, which is in the range of 5% oxygen, not 21%. But then we can come back to some very old considerations, because Helon, as you may remember, Helon was developed initially to be a vitreous substitute. That was the idea. And now it didn't work like that, but there may be some advantage in some patients from having a higher viscosity vitreous substitute. The silicone oil is that to some degree, but that has, of course, other problems. But maybe we should rethink the Helon idea.
Question? My name is Hari Kovács from Hungary. Congratulations, and I would like to ask if the arterial pressure doesn't change after vitrectomy, as we see, but the venous pressure is increased. It doesn't mean that the oxygen consumption of the retina is decreased. So for the oxygen consumption of the retinal tissue is probably more harmful than beneficial.
Thank you. This is a very, very insightful question. And indeed, as you pointed out, on the oximetry image and the data, there was no change in the arterial blood. Of course, that comes just straight from the heart, so you would not expect that to change a whole lot. But the change is in the vein. And it increases in the vein. So does that mean that there is less oxygen being used? It would appear like that. I think that a more likely explanation is that there's more oxygen coming from the ciliary body, from the aqueous humor inflow into the eye, which is contributing also to the retina, so that it is not that the retina is using less, but some of what it is using is coming from the anterior part, from the ciliary body and the pars plana. So this is supplementing to the retina, and thus the contribution from the retinal circulation proper is slightly reduced. So I think that is a more likely explanation than an actual reduction in oxygen consumption.
Thank you, Einar. One last question.
Thank you, Christian Faulkner-Radler from Vienna. Just one question. Would you consider to do vitrectomy in exudative AMA who are non-responders to anti-VEGF, or do some combinations?
Well, one always has to be, careful in going from, basic physiology to clinical recommendations. But I can tell you there is logic in that approach. There are some clinical papers that have suggested that a vitreoretinal adhesion contributes to neovascular AMD, so that in reverse, if the vitreous is lifted away, that would be a positive thing. And from the standpoint, from what we know about vitreous physiology, the mechanism for that effect is obvious. So I tend to believe that those clinical observations that have shown us that vitreous adhesion is bad if you have neovascular AMD, that those are correct, that those are not only clinical observations, they're also supported by what we know about physiology. So then you could say it would be logical to perform a clinical study on vitrectomy to improve neovascular AMD. So yes, I believe that should be studied in a clinical trial.
Thank you very much.